All right, well, let's go ahead and get started. I know it's a busy day today. Thank you for taking some time with us. This is the second of a three-part series on strategies for revenue cycle success in 2021. So for those of you who attended last week's session on price transparency, we're going to be building on some of those themes around Chargemaster and pricing. So let's go ahead and start with some introductions. My name is Brad Josephson. I'm the Director of Marketing here at PMMC. And PMMC is a leading provider of revenue cycle software and services. We have about 400 hospital clients across the country. And then also with me today is Tara Bogart, Vice President of Revenue Strategy at PMMC. Tara has about 20 years of experience working with hospitals on issues related to today's topic of Chargemaster rate setting and price transparency. So Tara, thank you very much for being with us today.
Sure.
So before we get started, I'm just going to go over a couple of housekeeping items related to the session. We have 30 minutes scheduled for today, but we would like this to be interactive. So if you think of any questions, I do encourage you to ask those by entering those into your questions tab in your control panel, and we'll leave a few minutes at the end for questions. The other thing that we're going to be doing today is we have some offers for some of our attendees that we're going to be sending through the chat message feature. So you may see your chat bubble light up. It'll light up like a red color. So if you see that, open that up because we'll be sending some private chats throughout the session. So let's go ahead and get started. I want to get some audience feedback right off the bat. And related to our topic for 2021, I'd like to get a feel for the audience. What is your primary objective for 2021 when we're talking about pricing and Chargemaster changes? So I'm going to go ahead and launch this as a poll question. And if everybody could get the votes in, we're gonna have quick results. We're gonna know the results right away, and we'll share those with the audience today. So again, the question: what's your primary objective for 2021 in terms of pricing and Chargemaster changes? And then the options here are increase net revenue within our contract caps, remain net revenue neutral and shift prices around where we can, or use the new price transparency data to drive our strategy. So it looks like most of the audience has voted, and I'll go ahead and share those results. And so about half the audience intends to remain net revenue neutral, or I'm sorry, intends to increase net revenue within our contract caps. The other 40% plan to remain net revenue neutral and shift prices around where we can. And then about 10% of you say that you're going to utilize the price transparency data to drive your strategy. So as I turn it over to Tara, any feedback on those responses?
Yeah, Brad, I expected the majority of organizations to land in that status quo bucket of kind of in the middle, but we can probably blame COVID-19 for people really working on their revenue. Times are tough right now, but I think everyone owes it to themselves to wait for the new data and then decide on a strategy. There could be some surprises out there. So, you may end up doing the same thing you've done in the past, but just to at least take a look at that data before you decide what route you're going to take, I think would be smart. But I'm going to, hopefully I'll give you a few things to think about during the webinar. And I know we have a few attendees today who have heard me speak on Chargemaster best practices. And many of the best practices really are unchanged, but as we approach price transparency, the status quo that's worked for organizations for so many years is going to need to be shaken up a bit. So today's session is on successful Chargemaster rate adjustments, not price transparency. But the way I see things, especially today, is that the two go hand in hand. So I do want to touch on transparency for a minute and what it's going to do and how you need to look at your Chargemaster differently. So there are a lot of organizations out there that are so excited to check the box on price transparency and meet the 1/1 deadline so they can focus on other priorities. I totally get it. Some hospitals have procrastinated and hoped it would go away. It wouldn't hold up in court. It would get delayed. CMS would soften up because of COVID-19. But here we are today, less than 60 days away. And you probably have a short-term plan or you're working as hard as you can to meet that mandate. But let's talk about a long-term plan. So there's a pattern we're seeing with price transparency that indicates it's here to stay and it will absolutely be relevant for your future Chargemaster projects. Will you go back one slide, Brad?
Sure.
Here, okay, so I'm going to tell you a few things that have kind of led me to think that. So I thought today when I did this presentation, we would know if we have another 4 years of the administration that is pushing price transparency, but we don't know that yet. So time will tell. But there are other things that lead me to think that it's just going to keep coming. And we've seen 3 final rules in the past few years. So we had the hospital price transparency rule that required hospitals to publish just their standard charges in January 2019. And then the more comprehensive rule goes into effect January 2021. So you can see that it's gaining momentum. Well, just last week, CMS finalized the transparency and coverage rule. And that's basically pushing insurance for transparency, just like hospitals are being pushed. I'm not sure if you're familiar with this, so I'll highlight it quickly. It's very similar to the hospital side in that it requires health plans and individual health market plans to disclose pricing and cost sharing information, doing it in a consumer-friendly way. You must disclose in real time the rates they pay providers for specific services. And it also requires payers to provide not estimates for out-of-pocket costs for 300 services, but actually 500 of the most shoppable items and services, along with costs for the remaining procedures and drugs and all the other services. So another little detail on why I think price transparency is just going to keep coming is CMS has asked for the standard charge file to be published in a specific format, and it's the employer identification number, the hospital name, and then standard charge file.csv or whatever the machine readable extension is. So let's think about that. It's going to be easy for these websites to now be scraped and put into a format like Expedia or Cars.com. And the intent is to drive competition and give consumers cost information on their healthcare. So, think about it. What would your hospital look like on Expedia or on Cars.com? Would you be a good deal, a great deal, a fair price? It's really difficult to think that way. We haven't done that in healthcare, but I do believe it's coming. So I know many of you that are listening may not have been involved with price transparency. It may have been an initiative that managed care is taking care of, but I just want you to be thinking about the longer term implications of it, because if the CDM falls under you or your team, you need to start thinking about a strategy now so that you can be more proactive and less reactive. Okay, next slide. So one strategy that will certainly remain is balancing goals. So the exercise of changing Chargemaster prices has often been referred to as strategic pricing or charge optimization. And historically, hospitals would raise prices, which is kind of what the indication was on that poll, to maximize reimbursement within their contract limits. And services with percentage charge reimbursement could be targeted to optimize the revenue. And although strategic pricing has worked well for us, it is the cause for many hospitals having some services that are overpriced and some underpriced. And as part of the strategic pricing process, which maximize reimbursement, hospitals brought in market data to use as guardrails to prevent them from standing out. So they balance their goals but the net revenue was much more heavily weighted. So over the past 5 to 10 years, we've seen hospitals find a little bit better balance with a lot of neutral price changes, and we're likely to see a new trend when pricing transparency takes off to have the goal of rational prices and lower prices being much more heavily weighted than it ever has been before. Next slide. So hospitals need pricing that's rational to the customer, or pricing that's competitive with surgery centers, imaging, retail clinics, some of the non-hospital alternatives. So today, for many organizations, there are only a small number of payer contracts that have that percentage charge component. So the incentive to raise prices in these areas just isn't as substantial as it once was. So we need to change the way we approach pricing. And hospitals need to really rebalance the pricing with the underlying value and begin to move your commercial payment terms in that direction too, so that you don't lose margin in the process. But until the payers are unwilling to help align the pricing, hospitals are still going to need to do some of the more traditional tasks, such as paying attention to market data and the charge sensitivity of items, lesser of terms, things like that, while they're moving towards rational pricing. So today, it is still very important to know where you are in the market. Next year, you won't have to rely on Medicare data. There's a wealth of commercial data that's going to be published, and you can use this to understand your market position. Historically, it really didn't pay for you to be below the market charge. Low prices kind of equated to missed revenue opportunity, but it's now changing. With more price shopping and less charge sensitivity in contracts, lower prices really can be an advantage. So every hospital is different. Your ideal price position is going to depend on the level of competition that you're seeing in your area and the terms of your commercial contracts. So I'll share an example of a hospital that was really trying to rebalance their market position with some, they had a significant number of percentage charge contracts, and they decided they needed to have a 20% price decrease. And they were consistently high. So it wasn't just lowering a few things, it was major price decreases and a significant revenue impact. So the organization was financially very healthy, but leadership said it's time to stop riding the gravy train. So the organization was holding on to those large charge sensitive contracts, and you know, they did absolutely take a hit, but PMMC modeled a lot of scenarios and tried to minimize the net revenue impact. And you know, even though the hospital took a hit, you know, looking back, they sure were ahead of their time. They got ahead of price transparency, and today they're in a much better place because of it. So for most health systems or hospitals we work with, we've been able to have small annual decreases without impacting net revenue, or they've agreed to a multi-year approach that allowed them to spread the net revenue hit across a few years. The key point is our industry shifts to more consumerism, is we need to begin changing our mindset away from strategic pricing and more towards rational pricing methodologies. You know, something that takes into account the consumer and looks at the market in different ways. So many of you still have some of those smaller percentage charge contracts. And our mindset for so long was, my contract allows me to increase the charges, so I still need to do that. But we have to start thinking about things differently. We might be incentivized by contracts to make the price adjustment, but does this rationally make sense? And why not push managed care to structure the contract differently and remove the gross charge escalator, instead push for higher reimbursement? And speaking of rational, let's talk a minute about CPTs on your CDM with different prices. Next slide, please. Not all organizations have this, but many of you do. So for an example, if you have an X-ray with a CPT code that's listed multiple times in your CDM, perhaps through different departments, different departments have set them up, the codes for tracking, and prices have gotten misaligned over the years. They could be intentionally different, and in fact, I expect some of those HCPCS codes to be different purposefully, but a lot of times we see variances that are unintentional and really don't make sense. And we've seen many items that are priced anywhere from pennies to hundreds of dollars apart with no rational reason. So I guess listen up, for many of these price disparities, there'd be no net revenue impact if you just assign the same price, because they're either very seldomly used or they're reimbursed a fixed rate. So why not clean it up, make prices consistent and rational, and give those consumers a better shopping experience? So that's an easy one for you guys. So now let's talk about a more difficult task, and that's really making the move to rational pricing. And it requires you to find the balance on competitive pricing and the bottom line. So as you adjust prices, it's important to be able to monitor and evaluate that impact. It's also very helpful to show these numbers to administration or the board to help them weigh in on goals related to price transparency and consumerism. So these goals can compromise revenue, and scenario modeling is going to help you show that and help model different ways, and ultimately help decide where to draw the line for the organization. So in this scenario, the difference in draft A and B is isolated to a few MRI codes that are being balanced with increases to surgery and room and board. And being able to see the difference in the net impact helps this hospital decide just how far they can go without turning their financials upside down.
Thanks, Tara. So let's pause here if we could and just shift gears a little bit. So we want to get into some more detail on things like lesser of charges and pharmacy and supplies to really understand how that's going to impact net revenue. So can you talk a little bit more about lesser of charges?
Sure. Yep, lesser charges is a concept that we'll have to think differently about as well. You know, it's a clause that states payers will pay the lesser of the contractual reimbursement rate or the hospital's gross charges. And hospitals used to hire consultants to conduct projects that focus on lesser charges. And by focus, I mean raising those charges to make sure the lesser charges language doesn't kick in and chip away at your revenue. And this practice won't be sustainable in a more competitive market. So ultimately, the language will need to be removed, but it's here today, so you still have to address it. Okay, next slide, please. I want to go ahead and talk.
Sorry, it's a little slow.
Yeah, that's okay. I want to talk about pharmacy a little bit because, you know, we've talked about modeling, but I want to touch on pharmacy and supplies because those are areas that are often neglected from modeling because they're on their own markup schedule. So many have it carved out from the annual projects. And over the years, we found hospitals don't keep the cost and the market markup current. So many items have received prices when they were originally set up and they haven't been updated. So that's another area to pay attention to. But another reason these areas are really important is, you know, in the past, there hasn't been much data available for benchmarking, but it's all about to change. So the 1.1 mandate requires the National Drug Code to be published. And it says you must include a standard charge for any code used by the hospital, and including, but not limited to CPT, HCPCS, DRG, NDC, or a couple other codes. So I guess let me ask you a few questions. What are you guys going to do with this newly competitive data? Do you have a way to analyze it and address your prices during your next Chargemaster adjustment? Are you prepared to carve out new tiers to address some of the drugs if they stand out? Do you get updated cost data and adjust your prices quarterly or 2 times a year or just once a year? You know, what if a prominent drug has a huge price decrease in April and you have the price from December posted from last year? You know, CMS says you have to update 1 time a year, but as often as needed. So perhaps your competitor updates their files more often, and now you're going to look really high. So the point I want to make is not to update your file quarterly. You know, it is for you to think strategically about your next Chargemaster adjustment and how it really fits with price transparency. How can you adapt and do things differently to help you stay ahead of the repercussions from transparency and more consumer shopping? Next slide. So no matter if you're focused on lowering prices, you know, for those shoppables, lesser charges, restructuring your pharmacy charge tables and markups, again, modeling those changes through your historical patients and contracts is key to helping you find that right balance with your net revenue in this new era of consumerism.
Great, thank you. And what about getting started, things like project plans and who we need to get involved? Can you speak to kind of what best practice as far as those types of things go and what that's going to look like?
Sure. So the first thing you really need to do is broaden your conversation. Compile a team, to address pricing. It really can't be done in silos because so much of it's going to involve managed care and just bigger decisions for the organization. The group needs to analyze where they are today and where they want to end up. I recommend starting with transparency analytics. Make sure someone is assigned to pull in the data from competitor websites and aligning it with your own charges and reimbursement rates. A big spreadsheet isn't going to be sufficient. There'll be a lot of data elements. There's just too much. You need to make it meaningful. So those who work with Chargemasters are very detail oriented, and it will take time to organize the data, but you have the skill set to do it. So, sort the competitive data by variation among price, service lines where you have great margins and really need to keep your volume. Highlight service lines at risk. And for each service line, know if you're competing with local hospitals or freestanding. If you are competing in the regional market, retail clinics, who is your competition? And then make the data work for you. The goal is to gain insight and help you formulate a strategy to protect your revenue and volumes, and start taking small steps towards rational pricing. It's likely going to be a multi-year approach. And once you get started, it's going to be important to monitor closely what's going on and be ready to pivot, because the competition is likely going to lower prices and make some changes as well. And they will also have negotiations that are occurring. So I would also encourage you to work with your payers to achieve rational pricing. Don't expect a big win here, but some might say you don't get what you don't ask for. I've spoken with hospitals that have made the request to negotiate terms out of contracts that keep them from lowering their prices. And the response is usually, no, we can't do that today. But I think negotiations will be different in 2021. Make sure you have a list of goals for your negotiations with each payer, so you're working towards realigning prices so that they make sense and they aren't just high because the industry drove them up. And then my last recommendation is to establish a formal pricing policy. This is a document that lays out how the organization is pricing items today and how they want to price items in the future. It may be set relative to Medicare fee schedules, commercial data, cost data, and likely a combination of these. But this document not only would give you a defensible methodology, it's also going to help you price new items as they come through and price them in a uniform fashion, which again helps you with more rational pricing. So once the policy is determined, charges can go in for the first few years and move towards that goal. You can apply some caps so there's no extreme changes to be absorbed, and it will really help you reach your goal, long term. So it can be done. Just involve a big team at the organization, anticipate different scenarios and know how you're going to pivot if they present themselves. Our industry, isn't used to real competition, with the exception of a little bit of lab and radiology that we've been dealing with for a few years, but it'll be a whole new ballgame. Patients won't run out to the website in January and change their habits. They won't. But over time, if you don't start getting ready today, I just think you're going to see trends begin to form and revenue dwindle. So it's just a good idea to keep that in mind as you move forward.
Awesome.
And that's all I
Thank
have,
you,
Brad.
Tara.
I'm open for questions.
Yeah, I'm hoping we get a few questions. We set aside a few minutes for any questions that the audience has. I know there's a lot of information in just 25, 30 minutes there, and a lot to think about for next year. So if you do think of anything in the next couple of minutes, go ahead and enter that into your questions tab. And I do have one here. So with the NDC code, does that need to be posted with the description or just the NDC and the price?
It needs to be posted with the description. A description of each item or service along with the corresponding code and charger required. Remember, the goal is to empower patients so they can price shop across settings. So they'll need the descriptors to be able to do that.
Okay. Great. And then we'll take a couple more here, one that just came across. Do you recommend a different strategy for shoppable services versus other services?
Yes. I recommend focusing on shoppable services so you can target these during your Chargemaster review. Know what charge codes are heavy hitters among your shoppable list so that you can flag them, and then you may want to decrease these and increase others that have the lower utilization among the shoppable services. So I know it's easier said than done since you've got the issue of multiple charge codes mapping to a service, but I think that if you map that out and really approach the shoppables first, that'll help you reach your goals.
Good advice. And if we don't have any other questions, I'll make one last final call for questions. In the meantime, we'll start to wrap up here as we're coming up on 30 minutes. We appreciate everyone spending half an hour with us this afternoon. And I do want to remind you that we have one more session coming up in this series, and I'll make a little plug for that now. Next week, Chad Shields is going to be talking about more of the reimbursement side and how you can start to put analytics in action to start identifying some bigger underpayment and denial trends, and then using that information when you start to renegotiate your payer contracts to help on the reimbursement side. So we hope you can join us for that session as well next week. And we will be distributing both a copy of the slides and a link to today's recorded session so you can rewatch that or share it with your team if you'd like. So thank you everyone for attending, and thank you very much, Tara, for your expertise today.
Thank you. I hope everyone has a great rest of your week.